Okay, so as Jeremy said, we took the next part of the project, forests and trees, to try to address some of these challenges and look at new methods to explore heterogeneity and give more informative estimates of intervention effect to decision makers. So the first challenge of better specification and effects of the components and better specification of effect modifiers, we sought to improve through using synthesis with hierarchical meta-regression. The second challenge, fourth challenge of poor reporting, we sought to improve through the design and delivery of an author survey, where we sought to get more information both about the interventions as well as potential effect modifiers, including more details about the intervention, more details about the population and the setting in which it was delivered. Third challenge of the intervention description, again, we tried to get through the author survey, but also we did some secondary analysis with collaborators using an alternative taxonomy to try and see if we define the intervention using a different approach, would that give us more information? But what I'm going to focus on right now is the synthesis with the hierarchical meta-regression. So in a standard meta-analysis, that when we're looking at the multiple components and those components can be combined in different ways, then the number of combinations that an intervention can take on starts to grow quite rapidly. So if we have K components of interest, so in our case we have 12 quality improvement strategies, that could work up to approximately 4,000 different combinations. If you have 10, about 1,000. And if we had something as great as the behavior change taxonomy, which has 93 components, it's many, many, many more. So it starts to get quite challenging if we're trying to look at information of all those different combinations using standard meta-analysis approaches. And so the first challenge is data sparsity. So as Jeremy was describing, the standard meta-analysis approach tries to learn across studies that are similar enough in terms of their interventions, but also in their comparisons. And in the case of the diabetes review, this is quite rare. So what this shows is the number of unique combinations of interventions within our review. So for 12 quality improvement strategies, we could have over 4,000 different combinations. But what we see in our review is really there's only about 90 unique combinations of the different quality improvement strategies. So that's audit feedback and case management, audit feedback, case management, team changes. So those unique combinations that have been observed. And mostly those combinations have been observed just once, with a few of them being observed enough times that you would feel confident in doing a synthesis of those particular combinations. So we have quite a sparsity of data problem. The second challenge, and one of the most important ones, is confounding. So when we're doing these synthesis, you're getting just that average effect, and it's not able to control for the effect of the different components. So several applied work, like the Lancet review, tries to tease out the effectiveness of the components by doing kind of a simplified version of the presence or absence of that. But really what that's doing is assuming the effect of the intervention is based on that component and is not able to control for the co-occurring effects. So it's likely overinflating the estimate of the effect of that component. And then finally, information loss. So in order to support that pairwise synthesis structure, various data reduction strategies have to occur so that we can do this synthesis. So in order to do the difference, we have to have two arms. So if it's a multi-arm study, we reduce it to the most versus least active. And importantly, all components are reduced to that difference of components. And I'll show an example of that in a moment. So this is the standard meta-analysis model, and the main thing to take away from this is that it's a difference. So the estimate of the study effect and the overall meta-analysis effect, you're estimating one parameter, the difference of the average effect of doing this complex intervention, which can be described in these various versions. And so what this is essentially one row, one estimate of effect per study. As I said, if 2 arms are included, it's only 2 arms can be included, sorry, the most versus least intensive. And then we do this differencing approach. So if there are active components, if it's an active intervention arm, which is quite common in our review, what ends up happening is the difference effect, that one effect per study, is assumed to be the difference between the arms. So if a trial had component A, B, and C in one arm versus C, really what that, in the standard model, what this is giving us is information about A and B, and the component C is lost, even though it may be contributing to an effect. So what we tried to do was give a bit more structure to isolate those components, but also try to estimate their potential effect modification by other factors by introducing a hierarchical structure. And what this does is we separate that study level effect into the arm level effect, so the average effect per arm. So we have an observational part, the mean of the study, which we assume to be a random variable, and we're estimating that at the arm level and at the study level. And then we have the structural part of the model, which we set up to assume what are the predictors that are contributing to that mean effect at the arm and then study level. And in our case, we estimate the parameters for each of the components of interest. So the beta K there, each component, each quality improvement strategy that we would like to determine the independent effect of has its own parameter that it's being estimated and being assumed to contribute to that final effect for the arm. And then ultimately we're estimating the overall effect of the parameters across the studies. So what this does is one row of estimate per study. This allows us to we're not losing information about the components of our arms. All arms get to be included and all intervention and control components get to be considered. So by treating this as a meta-regression, we get to include all relevant data, and it allows for the estimation of those individual component effects. What I presented there was the base model, but we can extend this model to assess important interactions that we might consider, so interactions between the components. So maybe we consider team changes as more effective with clinician education, and so we can explore if these components are acting synergistically or antagonistically. And we can also explore effect modification of these components or their combinations by population setting and contextual factors. It's also a really convenient structure to account for data limitations in a principled way. So often in meta-analysis, you may be missing information about the variance of the estimate. And in our cases, there was a large proportion of cluster trials which were not appropriately analyzed to account for the clustering effect. So essentially their variances are not appropriately analyzed. So we can, this allows us to impute at the arm level and study level in a really principled way. So what I'll do now is walk through the case example of us applying this meta-regression model to the Lancet data. So specifically for the HbA1c outcome, where we used 111 studies and 241 arms. We implemented a series of the hierarchical models to isolate the effects of the QI strategies and compared this to using the standard approach. So the first analysis was the standard meta-analysis and using just the pairwise data. So we eliminated multi-arm studies. We reduced multi-arm studies to just 2-arm studies, Analysis 2 used the hierarchical meta-regression, so the new model, but just with the pairwise data. And then analysis 3 used the hierarchical meta-regression, but with all available data, so all arms within all studies. And then I'll go through some ranking, application, and other model extensions. So what this table shows is those 3 analyses. So the first analysis is a standard model, is essentially a replication of what Jeremy showed before. So all of the components are effective, but there's a lot of overlap. But analysis 2 and 3 show that a smaller isolation of the component effects, and the slight adjustment of the ranking. So team changes, for example, is still the most effective, but is less effective. And there's fewer components that cross that line of significance. And so even though they're having effect, they're not as significantly effective as before. But we feel that this is likely more realistic and likely assessing the unique contribution of these components. And the difference between analysis 2 and 3 shows that by including all additional data, all available data, that we're able to get more precise estimates. So there is a benefit to including all arms versus just the 2 arms. We also did ranking, so these models can be used to estimate the ranking of the components. So these are helpful for communicating with decision makers, as it estimates the probability that each of these components, how well they would rank. So for example, team changes, the second one in the middle, has a higher probability of more commonly being ranked in the top 3. So that would give us a bit more confidence in communicating with decision makers that an intervention involving team changes may lead to better effects. We also extended the model to assess our assumption of it being additive, so we can see if interactions are occurring between the components in a non-additive way. And essentially, when we do a pairwise comparison between each of the QI strategies with each other, there doesn't appear to be any significant interactions occurring, which gives us a little bit of faith that the additive assumption may be appropriate or not completely far off. We also explored effect modification by the population factors. So as Jeremy showed, there did suggest in the Lancet that baseline HbA1c was modifying the treatment effects. And so we essentially reproduced that in the hierarchical model by including a binary covariate with baseline risk. And right now we're still exploring this, but it similarly to the Lancet, it shows that there may be more or less effect depending on baseline control, but these effects are smaller than those that were estimated in the Lancet and not quite significant. So synthesis with hierarchical meta-regression, we consider them to have several benefits. It allows us to include and model the distribution of the data within each study, within each study arm, and allows us to use all the data from all the studies, which in turn allows us to identify that average component effect for each component of interest. It also allows us to model the potential effect of effect modifiers and can be extended to incorporate really good approaches for imputing missing data. But importantly, can help us predict the effects of yet unrealized combinations. So if 90 of these potential combinations of 4,000 have only been observed in real data, and we're isolating an assumed effect for these individual components, this might help us start to understand what potential effect could be observed for those other combinations that have not been tested in trials. And all of these are an augmentation over the traditional approach. The limitations, however, so we have potential 4,000 main effects that could be assessed through multiple meta-analysis or a network meta-analysis, and our regression uses only 12. We're estimating only 12 parameters, and we're assuming that those interactions are negligible. But like all modeling, there's no free lunch. All results are conditional on the model being correct. Most importantly, that we've specified those intervention effects appropriately. And as Jeremy said, the taxonomy within this field is not quite defined. It's still evolving. There's many taxonomies to choose from. And those choices are extra evidentiary from what we have in the trials and within the model. So we have to make those choices and be comfortable that what we're putting into the model reflects the reality. And then, of course, it inherits all the challenges of traditional meta-analysis, such as publication bias, reporting bias, and missing information, which we are still addressing through incorporating information from the author survey.
Good. So I'm just coming back online. So hopefully what you've got a sense is that there's actually a very significant body of evidence about QI strategies. And Kristen's just presented the analysis where we've reanalyzed the original Lancet data, but we have been doing an update of the diabetes QI review, which we hope to publish in Cochrane later this year. And we've identified now 278 trials published by 2015. And yeah, this actually potentially gives us a lot more opportunities to explore even further factors in the data. But I think our experience through the diabetes QI work and other systematic reviews is that traditional approaches to meta-analysis and meta-regression only provide limited information that's insufficient to the needs of decision makers, and that there are opportunities to basically use more innovative approaches that will maximize the learning from an existing body of evidence. And these include things like novel analytical approaches that Kristen has summarized today, and also we're also, as Kristen has mentioned, basically looking at whether contacting the authors can enrich the data set, and if we try different ways of classifying interventions, whether that might also sort of basically enhance the value of these reviews to decision makers.